Ladies and gentlemen, welcome to our presentation today. Is the title, The Value and the Future of CT Colonography. As we know, CT colonography, or known as virtual colonoscopy, is in fact a quite straightforward procedure, and it's got the ability to investigate large bowel, and at the same time it has the ability as well to assess the structure beyond the large bowel, such as the chest, abdomen, and pelvis. So it's coming quite popular over the last few years, and in fact it's been quite taken over the conventional CT scan and colonoscopy. And therefore, we aiming from this study is to look into the value of the CT colonography as compared with the conventional colonoscopy. That in particular group of patients which is proved to be quite difficult and challenging to complete colonoscopy procedure, and assess the possibility of considering CT colonography as the first line treatment or the modality, diagnostic modality in this group. So here it all comes, for myself as a surgeon, as well colonoscopist, I found quite challenging to do colonoscopy in this group of patients. The elderly, female, frail patient coming with history of abdominal pains, irritable bowel, and as well risk factors, which I'm going to talk about in the next few slides, of female patients who had a history of hysterectomy. This group of patients doing colonoscopy sometimes quite challenging, and on the other hand, we have the new emerging technology, the CT colonography, which is, we noticed, it's a backup. So when we fail to do colonoscopy, we always ask the help for the radiologist to do CT colonography. And it is exactly the same group of patients. The frail, elderly, with the risk factors for inability to complete colonoscopy, and at the same time it has the appropriate sensitivity and specificity as well for the diagnosis of colorectal cancer and polyps. So, therefore, I looked into, we did a retrospective study on the data. We have basically very active, busy radiology department in our hospital, which is it's Diana Princess Wales Hospital. It's in northeast England. So they did basically in a year around 469 CT colonography. That's between January 2015 and December 2015. When I looked into the data, of total 469, we have 259 which they had only CT colonography, 52 CT colonography and colonoscopy, and 158 which they had CT colonography after failed colonoscopy. So basically, colonoscopy failed, was incomplete, and then forwarded to a radiologist to do CT colonography. And this is the one which I have extracted, and I looked at it. But when I looked into details of this group, I found I have to exclude 56 patients because some being cancelled because of poor preparations, colonoscopy cancelled because of poor preparation, and some they had flexible sigmoidoscopy instead of colonoscopy, so it was labeled wrongly. So I ended up with a total of 102 patients exactly who had CT colonography after failed colonoscopy. So we retrieve the data through the radiology report, colonoscopy report as well, and we have a software as well. We can access all the patient details of their clinical tendency and background, all the things. So, and we measured age, gender, indications, and if there's any history of abdominal pain, history of hysterectomy, any major abdominal surgery. As a total, we had 18 male, 84 female, which always statistical significance in terms of their of the number. So we had more female which they went to have colonoscopy and failed. I mean, regarding age, which is median around 66, 65.5, so it just doesn't make much difference. But we have the eldest female who's 94. Can you imagine to have 94 patients go on the table to have a colonoscopy, which I believe is quite difficult. So whoever been through or heard about this colonoscopy is quite a difficult procedure to go for half an hour with a telescope in a 94-year-old is quite difficult. And as well 83 for the male. This is the indications why you're being referred to have a colonoscopy. We have, which is not a surprise, it's also for a change in bowel habits. FOB positive, there's a blood in the stool. We do it as a cancer surveillance sometimes as well. And for anemia, we have 23. Polyp surveillance, 8. 12 between weight loss, follow family history of bowel cancer. PR bleeding, 3, because usually PR bleeding we investigated with a flexible sigmoidoscopy rather than full colonoscopy. But it's still a few where the PR bleeding had to be referred for colonoscopy. We use for the colonoscopy 2 types of sedations, Intonox or midazolam and fentanyl. So it doesn't make, I mean, usually Intonox we give it to patients who haven't got someone to stay overnight, because when you want to give sedation, you have to keep patient with accompanied friends or family for 24 hours. And usually we give 5 milligram midazolam and 100 fentanyl. So it's reasonable, very good amount of sedation. So sedation is not a problem. And usually for the elderly we have the dose, but always we start with a low dose and we can increase as it goes. So we have reasonable amount of sedation to keep the patient comfortable. Now this is a picture of the why it's been incompleted. So we have, in fact, the majority was due to pain, which is as well not a surprise that when you have pain you have to stop. Around 79%, and 16 patient looping. There may be overlapping between looping and pain. Looping can cause pain if you're not able to go through the bowel, navigate, you get the scope bended, and then the patient might have pain. So looping and pain probably the same, but we just written here what is being reported by the colonoscopist. 81, 79% they reported the procedure has to be stopped because painful, the patient can't tolerate it anymore. And 4, there's been acute bend, couldn't manage to go around it, so they have to stop it. And 1 patient developed bradycardia on the examining table, and the procedure has to be abandoned. The failed site, where it's failed, the majority, 63%, in the sigmoid. And as well, it's not a surprise, the sigmoid is the main site which is we struggle to navigate through because of the anatomical position, the length of the sigmoid. So it's a challenging, and most of the time as a colonoscopist, when I pass the sigmoid, I feel okay. Hopefully I'll be able to finish and reach the end. So sigmoid was the main site for failure to stop, then followed by the splenic flexure, transverse colons, and so on. Cecum, two failed. They saw the cecum, but they couldn't manage to intubate. And if you don't intubate the cecum and you see all the wall of the cecum, the colonoscopy will be counted as incomplete. So you have to see the cecum completely. So this is the figures of the failure site. This is the advantage of CT colonography. So when this patient failed to have the colonoscopy, we sent them to have the CT scan, the CT colonography, which can look inside the large bowel, and as well can give you some information about outside the large bowel. Sorry, I think probably I missed that. This is the finding of the colons. I'll talk about this later. This is the finding of the colonoscopy, what we found here. We have 85 normal, 55% did not show any pathology, 36 divertical disease, and 6 polyps, and the polyps 3 in the sigmoid, and 2 in the rectum, and 1 in the cecum, and all polyps being around 6 millimeter. The maximum size was 6 millimeter. 2 had the stricture. That's the slide about what the CT scan showed when they failed to have the colonoscopy. We may argue about the CT, be interested in a problem with the bowel, why we should have overdiagnosis or worrying about outside the large bowel. But it's an advantage for the patient that you may detect early cancer, early pathology you may be able to treat, and that's what showed here. One patient had a lymphoma, and which I had in the brown here, it should be red, I don't know why it's coming. One had a lung lesion, undetermined the significance of it, but it's for further evaluation. And one had adenoid benign tumor. Another patient showed a pancreatic cyst for further evaluation. So, and their breast is benign hernia, few kidney stones, not related to their presentation. Gynecology caused cyst and fibroid tumor might not be relative of significance, but we had a few. So CT colonography can assist the large bowel and can give a bit more information as well about the structure beyond it if there's any interesting pathology we might detect a bit earlier. If we look into the risk factors, so 79 patients, we noticed that they have a risk factor that you won't be able to complete the colonoscopy. Risk factors counted as a prediction that there will be a difficult colonoscopy and you will not be able to complete it, which is in fact around 3/4 of the studied group. 23, absolutely fine. You can't say there's a problem here, it's just colonoscopy not completed. Further analysis of the risk factors, we can see here hysterectomy, which is, we know hysterectomy is when I ask the patient, have you had any history of hysterectomy? She said yes. Say, well, it will be a bit challenging, and that's because of the sigmoid in the pelvis will be, we remove uterus, sigmoid stuck in the pelvis, you've got a lengthy tortuous sigmoid, empty pelvis, scope will have problem here. So 26 patients had hysterectomy, 2 bulky uterus, big uterus, reported by the radiologist as a bulky uterus, and 12 patients had major abdominal surgery, long midline incision, lower midline incisions, multiple scarring. Scarring, you know, it can shift when you operate. Bowel could be shifted to one side or the other, and that might cause a problem with colonoscopy. And it's all well documented as well. They can create a problem with colonoscopy. Laparoscopic surgery, there's argument about laparoscopic surgery. It should be minimally invasive surgery, but it's still operations you move bowel as well, and there's report. There are records which is patient can come with adhesions and bowel obstruction after lap surgery. IBS and diverticular disease, which is counting around a good number, which they have irritable bowel. And imagine someone who's all his life having a problem with irritable bowel, pain in the abdomen, and diverticulitis, keep coming and going to clinic, and you're going to put a camera in their bowel for half an hour. They won't cope with the inflation of the air, and so they have a bit of sensitivity, and they appear to be a good number to ask to stop the colonoscopy. This is another figure to display this nearly third of female had hysterectomy, and hysterectomy well-known risk factor for incompletion. Mixed gender risk factors, just show you just numbers about how it's common to see that a number of risk factors, and they basically presented in patients who failed to have a colonoscopy. So 16% abdominal surgery, and I come back here again here of IBS and diverticular disease, which is really a good percentage of the studied patients who failed to have colonoscopy, and they presented with abdominal pain. I mean, the two patients here, approximate 2%, the two patients here, they are the 94, and the other one 94 female, and the other one the 83 male, they really frail. They're really frail, hardly they can get into the examining table. So how on earth someone requesting to do colonoscopy and expect this will be able to complete? It is a difficult procedure. It's not a picture to take. It's difficult. But here we are, not completed. Okay. So the question is, colonoscopy the right choice for this group? So if I'm a physician in the clinic and I have a patient coming with PR bleeding or changing bowel habit, and they're coming into that category, well, I have to think about it. 94, is she suitable to have colonoscopy? So colonoscopy is quite challenging, it's difficult, it's tiring for, if it's in this group, it's tiring for the colonoscopist, for the nurses and the patient as well. You waste resources, and it's costly as well, running out of time. So there are a lot of things can happen when you face difficult colonoscopy, and it's not without risk. Perforation. If you perforate 94-year-old female or male, I mean it's sentenced to death. They will die. So it's serious. When we request CT, when we request colonoscopy, we have really to be sure is this patient able to have it done. And do we have alternative? Well, yes, I think we have alternative. CT colonography. It's simple, straightforward, take 15 minutes. The patient will come in on the examining table, they put some air, and they do some imaging, and this will be analyzed, and we'll see inside the large bowel. And if there's anything interesting, and this is what happened, this is what I do, I send the patient for CT colonography. First, we examine the first 10-50 centimeter with a simple scope in the clinic, because the CT colonography may not be able to identify the rectum. And then, if the CT scan showed polyps or suspicious lesion in the sigmoid, then you can bring the patient, and there's something to justify that you need to do that and take biopsies. And it's well tolerated. It has high sensitivity and specificity to detect polyps, different sizes. So it's not far from the colonoscopy. Yes, you can't do therapeutic at the same time, because colonoscopy you see and you treat, but not always you can treat. If you see a large polyp, you have to bring patient another day. Simple polyp, yes, you can remove it, but this is not significant in terms of complication which may get. So CT tomography is the choice. So is it in EU? No, I mean it's these risk factors is well known. It starts from 1995 when an American study looks into nearly 1,000 patients with a failure rate of around 9%. They couldn't manage to complete it. And they found female in their study, which is a higher rate for incompletion, which is quite statistical significant. And hysterectomy was clear. One of the major cause of inability to intubate the cecum was quite statistical significance. And the sigmoid colon was as well one of the major sites for inability to complete. So we know that colonoscopy is difficult here. Yes, we know about it as well. It's published, this data published in 2007. It's as well a very big study in America as well, in Ontario. They look into around 300,000 patients who went to have a colonoscopy with a failure rate for completion around 13%. This is around between 1999 and 2003. And they came to a conclusion, yes, colonoscopy is difficult in this group of patients. Elderly, female, had abdominal surgery, pelvic surgery, and hysterectomy. So we know it's difficult. Last one, and I found that quite interesting in the literature. It's about the anatomical variations. Quite interesting study here as well. As well in the US, they looked into 100 patients who had CT colonography after incomplete colonoscopy, and they compared it with a control group. So they had 100 patients first who went to have a CT colonography after failed colonoscopy, like our study, and another group, control group of 100 patients who had a complete colonoscopy after CT. So they looked into their data, and they found as well it's the main interesting here. There are differences. Female more difficult to finish. The elderly as well is with obvious statistical significance. But abdominal surgery, the same conclusion. Prior abdominal surgery was 26% in the complete to 48% for the one who has CT colonography after failure. So abdominal surgery is a risk factor here. And the interesting one is the length. I mean, we think that the colon is around 1 meter, but interesting here, when they measured the colon, I mean, there's here colorectal length in the group who had completed colonoscopy was 167, the mean, compared to around 2 meter, the one who failed. So the length of colon sometimes could be a factor. And I see, and so when I go there, I say, oh my God, I can't finish it. I mean, how tall this guy is? It's just you go through one corner, another corner. I mean, indeed, and it's not 1 meter. Sometimes you have 2 meter colon. And sigmoid as well, 66.8. You expect the sigmoid around 15 centimeters, something 20 centimeters. You have here the failed one, which they couldn't manage to complete it. It's 67 centimeter. Transverse colon as well is longer in the failed group. And the number of flexures. I think we know that the sigmoid flexure, okay, I finished the smell, that's fine. Then I have the splenic flexure and the hepatic flexure. I believe that I finished. No, I mean, here you have, in the third group, you have 12 flexure to go through the colon. And this is where you will have difficulty. So the colonoscopy is very difficult. In the UK, forget about being a surgeon or physicians, but to be able to do colonoscopy and endoscopy, upper and lower, there is a special training, national training. You have to go into over 200 supervised, another 200 supervised next to you, and so it's a long training process. It might take you 4 or 5 years to be qualified, and it comes from a special department in the UK to allow you to do colonoscopy independently. Whatever your specialty, even if you are being a surgeon for 20 years, but if you don't train in colonoscopy and endoscopy nowadays, you are not allowed to do it. Even if you do everyday major colorectal surgery or stomach surgery, but if you're not trained and approved by JAG training body in the UK, you're not allowed to do. It's quite a serious test to do, and it has to be really fully qualified to do that. So, as you can see here, so there are many factors, and we know this all risk factor for the failure. So why we still do that? So in conclusion, colonoscopy, although it's well known as a procedure for investigating large bowel, but it's not without risks and difficult in particular group of patients which I highlighted here. CT colonography is basically proved to be a safe and successful procedure, and we believed in this study that we should accept CT colonography as the first choice in managing this group of patients with a high risk of failure.